without any further ado, I'll just let David go ahead and explain his journey and his path, and I hope you enjoy it.
Thank you. My title is a bit pretentious, but I'll let you be the judge of that as you see how this story develops. I don't have any individual benefits from any of the entities mentioned here. I hope that this will be more than just an interesting talk, but useful for you. I want to illustrate how small beginnings can create breakthroughs in surgical training, demonstrate how a lack of resources can be fertile soil for surgical innovation, show how PAACS used, and I'll just explain what PAACS is, used strategic partnerships to create this breakthrough and motivate you to get involved in improving surgical training in the developing world. My small beginning, talking about the importance of small beginnings, was actually in Cambodia, where my parents were missionaries. And we were in the hospital, and let's see, how can I use a pointer here? Probably, maybe, well, you see in Cambodia the country named, or a city named Krache. That's where we were located. And there was a guy named, actually a doctor, physician named Tom Dooley. I don't know if you ever heard of him, but he had been a Navy physician during the French Indochina War. The United States was involved helping France briefly in what later became North Vietnam. And after he left the Navy, he really had a heart for helping out the peoples of Laos and Cambodia. There was no health care after the French had left. They closed all their hospitals, all their French physicians left. And so he set up something very similar to Doctors Without Borders. And this was back in the 1950s and the 1960s, and one of his hospitals was in our town. They actually moved into the previous hospital that the French colonials had left and reestablished it with volunteer physicians. And so I would go there and sort medicines out for them. They were donated medicines. That was kind of my early inspiration and interest in medicine. When I was 14, this hadn't really coalesced into anything concrete in my thinking, but we saw a man die alongside the road following a terrible road accident. There was no place to take him. Nobody knew what to do. My father was a pastor with some emergency training, first aid training, and he tried to help him, but the man died. And that was very shocking moment for me. I began at that point in my life to actually ask God to help me to become a physician and to help people like this man in countries where there wasn't health care, to help them to have health care. And then finally, when I applied for medical school at the University of Pittsburgh, the surgeon who interviewed me was at that time the chief of pediatric surgery of the Society for Pediatric Surgery in the United States, Dr. William B. Kieswetter. After the interview, he said, I'll do everything I can to help you be admitted to our medical school. And he was as good as his word. And afterwards, he said, since you don't have any money, you're welcome to come and live with me. So this man really invested in me. And this made a great impression on me and really impacted my life. I want to talk about partnerships, the importance of partnerships. And I'd have to say that my first important partnership is mentioned in Psalm 139. If I ride the wings of the morning, if I dwell by the farthest oceans, even there your hand will guide me and your strength will support me. No matter how smart we are, no matter how determined we are, we really cannot work alone in difficult environments as physicians, as surgeons, without help and expect to succeed long term. We can do things short term, certainly. And so I asked God to help me in this endeavor and bringing medical care to people in developing countries. And I have to say that God never let me down. My second key partnership was my wife. If you're a little shocked by the jacket, my mother-in-law gave it to me, and I had to wear it for that picture. This picture was taken in 1975, just as we were getting ready to leave for Africa. My wife was just a tremendous, has been a tremendous blessing. She's a nurse, and she was planning to do this before we met. The third key partnership was our sending mission. It was a church denomination, Protestant, and they had been in Gabon since 1933. And so there was connections. It was a very small mission, but their vision was to establish a hospital in the southern part of the country where there was no health care. And there were some missionaries there, but people were dying really in terrible numbers. The health care that area was so terrible. And they said, we can't possibly be talking to people about God and ignoring their health. So we had volunteered at that point, and we arrived in the capital city of Libreville, really quite clueless about what lay ahead. The road looked pretty good as we started out. It got more interesting as time went on. The pavement ended by the time we got to Albert Schweitzer's hospital in Lambaréné, and we kept going, and it looked more and more alarming as time went on, and we began to ask ourselves the question, what exactly have we gotten ourselves into? We thought we were going to be in an urban center, and it was getting more and more remote. It got worse. Pretty soon we were driving down a road like this. There wasn't any other traffic. And then this was called National Highway number 1 in the country. It's still marked that as in the map. Today it's paved, but then it wasn't. And this was the end of the road. There was this hand-pulled raft across the river about 75 yards wide. And we went across this river, and I was thinking, where in the world are we going? And so then when we actually saw where we were going, I was pretty shell-shocked by this point. This was the dispensary that we were supposed to turn into a hospital, in a little clearing in the jungle. We had no running water, we had no electricity, we had no surgical instruments, no operating room certainly, a lot of patients, and every night about 150 goats slept underneath the eaves of the building. So the place just stank. You couldn't walk inside without walking through goat poop. It was sort of a tetanus laboratory. And I just was so appalled. I just thought, how in the world can we do anything in a situation like this? But we had another key partner, and that was the local church. This was a group of very simple people, but who were committed to the same vision of providing health care for the southern part of the country. They thought that a doctor was all that was needed, and everything would just fall into place. Well, I was quite overwhelmed, but they were a huge help to us. They helped us to learn the language. We had already studied French in France for a year, tropical medicine in Antwerp for 6 months, and so then we arrived, and we had to learn a tribal language and begin to start working part-time. But they also helped us do some research that I'll talk about in a minute in our community to figure out the medical problems that we should address. And they helped us choose reliable people, local people, to train and work with, and they really protected us from people who wanted to take advantage of us. I would say that most of the Africans were very good people who wanted to help, but there were many people who wanted to take advantage of us as well. And we really couldn't tell the difference between them. So they were very important to us. And the project that we worked out with them and that they enabled us to do was to make a survey in 100 homes in the community. It was a very small community. There were only about 1,500 people. But at this point, the whole southern third of the country had no physicians. They had some locally trained nurses in the hospitals, but there were no physicians. And so we asked about the demographics in these 100 homes. We found out who in the family had died in the last year, and as far as the people knew what they had died from, who was currently sick and with what, and what were the biggest health needs in that community. And I can't take credit for this idea. We were just looking at the huge challenge in front of us, and this idea kind of popped into our heads. I think, again, this was a gift from our first partner, our Heavenly Father. But as a result of this survey, people began to trust us, and they began to know us. We came to their door. They knew we were coming because of our local church partners, and we said, okay, through translators, we said, we're here to find out what diseases your family has, what people in your family have died from, and that really was a wonderful way to earn trust. But we found that 100% of family members had symptoms of malaria at least once a month, and 2 out of 5 children died under the age of 5 from fevers that sounded like malaria. Many children under the age of 5 had measles. Pertussis was endemic. There were about 10 cases of polio, ongoing polio, new cases of polio in the community, and that was ongoing in the surrounding areas of the province. 100% of the people surveyed had scabies, and 100% of the people surveyed gave histories of having worms. So mostly Ascaris, but other worms as well. And there were surgical and obstetrical disasters. About every 5 households could talk about a maternal death, a woman who died in childbirth within the last 5 years. Every 3 households could talk about a neonatal death. Only 20% of the women in the region were able to get C-sections. This was in 1977. 10% of adult males had inguinal hernias, and some of them were huge. Some of them were down to their knees. So this was just, I'd never seen such surgical pathology. It was quite intimidating. But we set up our project then. We said, okay, let's see what we can do. We need a vaccination program. And so we basically dropped everything because these epidemics were killing large numbers of children along with malaria. Matter of fact, in our first year there, we had a fairly reliable estimate that 500 children died within 25 kilometers of our dispensary just in that 1 year. And about 100 of them died at our dispensary. That was very difficult. There was almost nothing we could do for these children. So we vaccinated them. We got vaccines, set up a cold chain, got vaccines from Europe. And I was a surgeon, but I became a vaccinator. We went every village we could find. We divided our small team up. We had 4 on our team, and we got some of our African church members to help us, and we vaccinated and stopped those epidemics. And that also earned tremendous trust from the community in the region. We got involved in malaria prevention and treatment of these, particularly of children, and teaching about using mosquito nets and all these other things. My wife set up a nursing school, and also from that school came a midwifery school. We set up a walk-in outpatient department and some inpatient beds, very modest buildings at the very beginning made out of mud brick. And finally an operating room and inpatient beds, small operating area that took 3 years to build. So that was our beginning. One of the things that really became evident even as we started, but as we continued, was that local partners are extremely important. Expatriate help in a project like this is wonderful. We came, we brought ideas, expertise, but unless nationals share the vision and are trained to do 90% of the work, the project will fail. It will ultimately fail. I've seen this happen many, many times in my 36 years of being involved overseas. The other thing that I came to appreciate is that small beginnings are very important. And Zechariah, this is another quote from the Old Testament, "Do not despise these small beginnings." Small beginnings are easy to despise because many of them fail, but they can also be extremely important. And we started small. Now my wife had gotten training with me in Antwerp in tropical medicine, and part of that training was a laboratory course. And so I said to her, we really need a laboratory. I know you're a nurse, but could you set up the laboratory? She gave me a long, dirty look, but she finally said, all right, I'll do that. But in exchange, she said, you have to let me start a nursing school. And I thought, all right, you know, that's not nearly as important as what I'm doing, and you can go ahead and do that too. That turned out actually to be critically important, and I didn't realize that at first. But she did start the lab. She trained someone to do very simple laboratory tests, but the nursing school was her main passion, along with a couple other missionary nurses that came out. And over the years, they trained over 200 nurses. Without that nursing school, we would not have had a national staff. We would not have had the help that we needed to expand the medical services, and that became very critical in the development of that project. Some of those nurses we trained as midwives, some we trained as lab techs. We had short-term lab techs come out and do some training courses. Even had a dentist come out for 3 years, set up a curriculum, and train 2 of our nurses to become dentists, and they're still working there today as dentists. They do everything. They even do root canals. But at whatever the hospital needed, we were able then to get training for local people. So 17 years later, our single building had kind of expanded to a 60-bed hospital. We had a busy outpatient department. We had a kind of a rudimentary emergency department, maternity, medical service, surgical service, ophthalmology, dentistry, lab, and x-ray. And so it was looking good. A lot of people were being treated and helped, and we were feeling pretty good about what we were doing. By this time, our hospital had become the major medical and surgical referral center for the southern third of the country. And that was wonderful too. We were gratified that that was happening, but I was totally overwhelmed. I was the only surgeon for about 250,000 people in those 2 southern provinces, and I was on call 24/7. I finally trained one of my nurses to deal with the 3 largest, most common emergencies, which were ruptured ectopic pregnancies, strangulated hernias that required often bowel resection, and C-sections. But even with that, I just couldn't keep up, and I thought I need to get somebody to come and help me. For some reason, I was not able to recruit another American surgeon to come out and work till he dropped dead. And so I thought, well, maybe I can find an African who will do that with me, because I really was working 120 hours a week. But what I found out then as I began to look for others to come and help was pretty shocking. I hadn't realized this, but when I started trying to find help, I found that most African countries, including the country that we were in, had no formal surgical training programs at all. That was in the 1990s now. I don't think that's true for any of the countries anymore, but their programs are not very formal. The rate of surgeons to people was between 1 to 250,000 and 1 to 2 million in many places in sub-Saharan Africa. Fewer than 20% of the women who needed C-sections could still not get them. And this was in 1994. And fewer than 20% of men who needed hernias could get them operated on. So this was pretty shocking stuff. Outside of our hospital and the capital city, the mortality for a strangulated hernia was 90%. And finally, the majority of femur fractures, orthopedic trauma was just a major problem. And the majority of patients, adults who had femur fractures, were just treated with bed rest. Some with traction, but it was ineffective. Most of them ended up with seriously shortened legs. And in children with femur fractures, they were crippled for life. Many of them would crawl around on the ground. The probability of death at between ages 0 birth and 15 years old was 22%, compared to 1.1% in the developed countries. I learned that only 5% of African surgeons were serving in rural areas. And in 1994, between 40 and 50% of the population in sub-Saharan Africa was rural. I learned that 10% of adult deaths in Africa could be prevented by surgical intervention, and 20% of pediatric deaths in Africa could be prevented by surgical intervention. This was a study that was published in the journal American College of Surgeons in 2001, where a researcher compared the number of operations per 100,000 people in developed countries versus undeveloped countries. One of those was Ethiopia, and you see the difference. It's enormous. And that was very similar to what was happening in Central Africa, where I was. Most of Gabon's few specialists lived in the two largest cities of the country, 350 miles away from where I was. The nearest hospital with a surgeon to where I was Schweitzer Hospital, which was 160 miles to the north. I was the only surgeon of any kind for 200,000 people. And so I had a problem. I couldn't find anyone to come and help me. And I being a person, I really have great faith in God's ability to help us. And I began to pray and I asked God, what should I do? I mean, I can't keep going like this. And I knew that if I dropped dead, everything that we had started would return to what it was before. At that time, I was not the only physician, but there were only two of us. There was a pediatrician who was with us then. And as I talked to God about this, the only answer that I heard him say was, train them yourself. And I thought, that is absolutely impossible. I am not the academic type. Others are more qualified. Nobody will apply to any kind of a surgical training program that we offer down here in this podunk hospital in the rainforest. We're not a university hospital. My family will suffer. This will just exhaust me because I already am overworked, and now this is going to double my workload. God really needs to find someone more qualified. Well, time went on. A couple years went by. I kept thinking about this, and ideas started to form in my mind. And I don't take credit for that. I give the credit to my first partner. But I thought if we had one board-certified surgeon per mission hospital, and there were a lot of great mission hospitals in Africa across the continent, if we had 5 to 10 visiting surgeons from the US or Canada, from developed countries who had shared our vision, they would come for 2 weeks or 3 weeks or 4 even. If we had donations to support our residents during their training, and if we set up a 5-year formal training program based on the US model, and we trained residents at multiple hospitals across Africa, we could make a difference. And so in 1996, I met with a group of other missionary surgeons from all across Africa. We met in Kenya. They were having the same problem as I was. They were just getting grayer and running out of steam and not finding surgeons to help them. And so I presented this idea to them, and they said, you know, this, I don't know, we don't know if this could work or not. Maybe the governments won't let us do this. Some said, we need to first go and ask permission. I said, you know, you all know what happens. If you ask permission for an idea that nobody can even dream of, they're going to shut it down. So it's better to ask forgiveness than ask permission. That became one of our mantras. And so they all said, okay, let's go ahead. We'll all do this. Turned out I was the only one who started, at least for the first 4 years. But the goal we set was we would try to train, mentor, and graduate 100 African surgeons by 2020 to serve in where they were needed the most. And at that time, we didn't have any money. We didn't have any applicants. We didn't have a lot of things. But we thought, this is a worthy goal. Let's try and do this. And other key partnerships began to develop because others heard about this and they said, this is a good thing. We would like to join in with this. And so we talked to hospitals in different countries. It wasn't all at once. We started at my hospital in Gabon, but then in Cameroon there was a Baptist hospital, and they said, we'd like to do this too. And then there was one in Niger, and then there were 2 in Ethiopia, there were 2 more in Kenya. Finally, the last few are in just this year, Egypt, Malawi, and Tanzania. Bangladesh was about 10 years ago. We know it's not in Africa, but we made an exception for them. We needed a university to give us credibility with the governments of Africa. And so We talked with the Loma Linda University. I did my surgical training my last 3 years at Loma Linda, and they were very supportive. They said, we would love to do this. And then other things like World Medical Mission, who sends us volunteers, MedSend. And then there are 2 colleges of surgery in Africa that we also develop relationships with, the College of Surgeons of East, Central, and Southern Africa, and then the West African College of Surgeons. So a lot of these partnerships began to come together, and none of them involved money, except the hospitals. They had to contribute, they had to provide furnished housing for the residents and the health care, free health care for them and their families. But with that, that was the only thing that was involved. And so by 18 years later, this is what we have. We have surgical training programs in 8 countries. One in Gabon General Surgery. In Cameroon, we have a very large program. They're about ready to also start a ENT fellowship. Niger, in a very remote area, has a program. Egypt, we started this year with 2 residents. Ethiopia has 2 large hospitals and both general surgery, and we may be starting an orthopedic residency there. Kenya has, at one large hospital, a general surgery residency and a pediatric surgery residency. And the other large hospital has general surgery and orthopedics, that's at Tenwick. They're thinking about starting a cardiovascular, cardiothoracic fellowship because they're actually, our program director there is a cardiothoracic surgeon, and he's doing some open heart surgery. And then in Tanzania and Malawi are general surgery programs, and Bangladesh is also. So the whole thing really started to take off. The first picture up there on the left, that's me operating on a table that I couldn't adjust. It was an old MASH table that was non-adjustable. I had back pain for every operation, but that improved. I got 1 resident, and the first guy was from Angola, and then the second one was from Madagascar, and others from different countries in Congo, and eventually from Gabon and Mali. And then this last one on the lower right is from Egypt, where we've kind of advanced. We're not just teaching open surgery now, we're also teaching laparoscopic surgery. The first laparoscopic procedure that we did in Gabon actually was assisted by Adrian Park. Some of you may know Adrian Park, and a laparoscopic surgeon, but he came out and actually did a couple of Nissen fundoplications, but he helped us get started with air insufflation. We couldn't get CO2 in Gabon, and that's true in some of these countries. You cannot get it, or if you do get it, it costs more than the cost of the whole operation that you charge the patient. So we had to be innovative, and Adrian encouraged us to go ahead with it, that there didn't appear to be any evidence that it was dangerous. We had to figure out how to get the air, and we couldn't get pumps that don't have some kind of oil in them, but we did find oxygen concentrators that have, their filters aren't doing any useful work anymore. They still have a pump. And so we would connect those up into our insufflator box, and it's a little slow, but it worked fine. So with that innovation, we've done over 400 cases since 2007. I keep trying to get, our plan was to present a paper at the American College, but my other partners there, the younger surgeons who came, they wanted to get up to 500 cases. They're very close now to 500 cases. So innovation is one of the things that has come out of training surgeons in Africa, and for me that's very exciting. PAACS, not only, PAACS stands for the Pan-African Academy of Christian Surgeons, but PAACS actually, after 3 years, gave me my life back. The first 3 years were pretty tough, adding that to my load, but as I was able to train these guys, they very quickly learned. We had huge caseloads. They had lots of surgical experience and learned quickly. And by the 3rd year, I had other people taking call and sharing the workload. It was just a joy to work with these guys. Very motivated, very committed young surgeons. And so let me just clarify here that our short-term faculty really became very important for us. They were not just an add-on. But our curriculum is in English, even in the French-speaking countries, because 90% of the surgical literature and teaching materials in the world are in English. They're not in French. And so all of our residents, they have to be fluent in English, even if they're from French-speaking countries or from Portuguese-speaking countries. And that also enables American volunteers to come who share the same vision of these hospitals, which are Christian hospitals, to teach the residents in the operating room, give lectures, and so forth. And so many come this last year for all of our training programs in Africa. We had 150 volunteers, surgeons of pretty much every specialty. And they gave, if you added up the value of the work that they donated, it was $2.4 million. So a very significant contribution. The other thing that having faculty from the U.S., and we have a number of professors from universities here in the United States who are involved, is that we could set up every 2 years a basic surgery conference to prepare our residents to pass the examinations for the colleges of surgery at their second year and then after their 5th year. And so this basic conference is held in Kenya. We bring all of the residents for the first 3 years to one conference, and this has really been a huge blessing. One of the guys in that picture, I won't point him out, is the PAACS surgeon who recently died from Sierra Leone, Martin Salia. He was, at the time that he died, he was one of 2 PAACS surgeons that we have trained who are back in Sierra Leone. The other one is a pediatric surgeon. And we actually have five of our graduates in the Ebola zone right now who are at risk. And Martin was actually not treating Ebola patients, but evidently he operated on somebody that he didn't know had Ebola. The patient was asymptomatic and he was exposed. So this is a great loss to us, and it's a great loss to Sierra Leone. He was one of only 5 formally trained surgeons in the entire country of Sierra Leone. So this is a major blow. So currently PAACS is training, we are training 60 residents in 9 countries in 12 sites in general surgery, orthopedics, and pediatric surgery. Our budget went from 0 to $500,000, and in 2 years, as it grows, as more residents come onto the new programs, we're going to be up over 80 residents. That's larger than any single other surgical training program in any country in Africa. So that's the largest, probably the largest, if you lump them all together, it's the largest surgical training program on the continent. If this slide is real busy, I won't explain all of this, but these are where our grads are. This isn't all of them, actually. I haven't updated this slide. So our grads are working in many places in Africa. You see Martin Saleh up there in yellow on the left for Sierra Leone, whom we just lost. But there are others who are over there. We have one of the only surgeons in Liberia is working at the Elwa Hospital and at risk as well. Well, in 2014, we were asked if we could start a surgical training program at an Anglican hospital up in Egypt. And my wife and I went up to see the program, and to make a long story short, we decided that we would go up and help start that training program. Egypt is a huge adjustment. The medical environment, the medical culture, and the surgical culture is so different from anything we experience in sub-Saharan Africa. It's been a big adjustment. You don't adjust Egypt, you adjust to Egypt. Good people, much more developed, but they need help in surgical training. So we were able to leave our hospital, which had grown up to 158 beds and very busy. By this time, I'd transferred the leadership of our training program to a very capable young American surgeon from Cleveland Clinic who'd come out and joined our team. And subsequently, 2 other American surgeons joined, and we have now a pretty good team. We have an obstetrician gynecologist, we have American internist, pediatrician, ophthalmologist who started her own training program. And so that's going on fine without us. They didn't really need us. And so we moved to Egypt, and that was 2 years ago. that we made that transition, started learning Arabic. I have to admit that my Arabic is pitiful. I can get by, I can get around. Fortunately, most Egyptian physicians speak English, and that is a big help. I have two residents right now who are in training. We're hoping to have more in the January, to have 2 additional residents. The Egyptian system, it's again a situation where we didn't go to the Egyptian Ministry of Health and say, can we open a residency program? It turns out that they have a system where residents kind of set up their own training programs unless they're in one of the few residents accepted into the university programs in the capital city. And so we said, well, maybe we can come in after their second year or in their third year of training, of clinical training. They sort of sign themselves up as apprentices. But in their third year of training, they take a government exam. If they pass that exam, they get their master's in surgery and they're licensed to do surgery. So we're just fitting into that paradigm. We're training them up. They'll take their exam. We hope they'll all pass their exams, and then we'll go on and for another 2 years, so they complete 5 years. My slideshow seems to have frozen here, but I am at the end of my presentation. The last thing I would say to you is that I really want to encourage you to get involved in helping training in Africa. I think it's far more effective than just going and doing some surgery, because it's increasing capacity. The greatest gift that we can give to developing nations is not ourselves. It's our knowledge, the skills that God has enabled us to have, we can share with others. And it's tremendously gratifying. I can't think of anything that gives me more joy than seeing a guy who comes in as a first-year resident. He doesn't even know which end of the scalpel to hold. And by the end of 5 years, he's doing major operations. He's doing them competently. And he's able to teach others. He's able to train others. And he's committed to taking care not of just people who have lots of money, but taking care of poor people as well. That's been our goal. And all of our partners have enabled us to do that. So with that, I'll just close and invite you, if you have any questions, I'd be happy to answer them.